The last part of this session, I want to talk a little more about biomarkers. And Pasi, we've talked a lot about PD-L1 expression, but maybe you can start us off by talking to our audience about what is TMB, why is that even being discussed, what's the rationale for using TMB as a biomarker?
So TMB, or tumor mutational burden, is a reflection of the total number of mutations that there are in an individual tumor. Tumor-specific mutations that would create new sort of immunogenic epitopes where the immune system would try to then go after that, and especially with checkpoint inhibition, then you have sort of more chances of the immune system to go after these neoepitopes or new proteins that are made by these mutations. And certainly this is a biomarker that has, I think, been looked at fairly extensively. First demonstrated that it has predicts outcome for single agent immune checkpoint inhibition, and of course has been looked at extensively now in the combination immune checkpoint inhibition, as well as more recently with chemotherapy and checkpoint inhibition. I think TMB is a complicated biomarker because there isn't a standard in terms of what we call positive in terms of how many mutations. They're often measured in mutations by megabase, and they're extrapolated from our NGS reports, or you get different results if you do more extensive sequencing like whole exome sequencing. You can do it from the tumor, from the blood. So there's various different ways of doing that, and in fact there are efforts underway in the US to kind of harmonize some of these efforts. So it's a fairly complex biomarker. I think the other challenge for the immunotherapy field with TMB is that you have to sequence somebody to get TMB. It is a 10 to 14 day or longer process to get the TMB, and whereas PD-L1 comes as an immunohistochemistry biomarker in 24 to 48 hours, and so that I think creates another level of complexity in using TMB as a biomarker.
Yeah, perhaps in what I just said, I was not extremely optimistic about biomarkers for small cell lung cancer. But now that you mentioned TMB, in the study on relapsed small cell lung cancer in the Checkmate program, the tumor mutation burden was looked at in a way of three tertiles: low, intermediate, and high. And in that experience, both for nivolumab as well as for nivolumab ipilimumab in relapsed small cell lung cancer, there were better response rates in those with high, not with low intermediate, but with high tumor mutation burden. And also the overall survival curve had a plateau at 20% in those with TMB high in relapsed small cell lung cancer, while the other two at 2 years were almost close to zero. So maybe there is a role for TMB in small cell lung cancer.
So if we were to look at TMB, obviously, Pasi, you mentioned what is a threshold, right? What threshold indicates who would benefit and who would not benefit? Do we have that, you think, among all the studies that we've looked at?
Well, I think there are some thresholds that have been identified based on sort of panel-based sequencing, and you have to have probably sequence in the 300 to 400 gene range in order to be able to comfortably assign a threshold. So most sort of the commercial NGS panels that do that can assign that, and they put those typically in the reports. If you do whole exome sequencing, that's a whole different thing. And also these should be mutation in cases where you sequence the germline to know that are they germline variants or not. I think that gives you another level of clarity where the TMB is. Now, some of these have come from clinical trials. The points have been picked, the values have been picked, some from blood, some from tumor. So we have some, but I don't think we have a consistent number to say that it has to be this across all panels before there's a benefit. So there's some variability there.
So blood-based TMB versus tumor-based TMB, how good is blood compared to the tumor?
There is a very good correlation between blood-based TMB and tissue-based TMB, especially if you look at the data from MYSTIC trial. So there is a concordance based on data, but we need a tumor tissue, large amount of tumor tissue to have a tumor mutation burden in the tumor tissue. So that's why we really need a plasma-based TMB analysis. So in the MYSTIC trial, the blood-based TMB was predictive. So if we have a blood TMB at the cutoff of 13 mutation per megabase, it was predictive for a PFS and as well as overall survival to durvalumab and tremelimumab combination versus chemotherapy. So although, as Dr. Pasiani already mentioned, there is a lot of controversy for blood or tumor-based TMB regarding cutoff value and platform, cross-platform validation, and so on. I do believe for the future, we need to elaborate blood or tumor-based TMB for immuno-IO combination therapy development.
And Johan,
yeah, but it's clear. I mean, we don't have to expect an absolute cutoff in TMB to be there because it's a continuous biological phenomenon. It's the same for PD-L1. Even when you're PD-L1 high, there are data that you do better if you have 95 than when you have 55. So there's never an absolute cutoff in there. We need to find a test that is clinically applicable with a certain cutoff, but it's a continuous biological phenomenon.
Absolutely agree. What do you think we know about the correlation between PD-L1 expression and TMB in a given tumor specimen? Are they linearly correlated or not?
No, they're not. There is a certain concordance on average 1/3 of the patients, but there are patients that are tumor mutation burden high and PD-L1 low, and the reverse is there as well. So no, they're not concordant at all, and perhaps that's not a real surprise because it's a biomarker that is present in a very different position in the cancer immunity cycle, so they're not necessarily linked, and so probably, and that's what we have to find out over the coming years, they are additive, and in some situations one should have more weight, in other situations the other should have more weight, perhaps they should be both taken into account, and it's my feeling we're not there yet. We don't understand the full picture, but hopefully over the coming years more clarity will arise there.